Before studying the subgluteal approach to the sciatic nerve, it is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy. The continuous sciatic nerve block is indicated for painful foot and ankle surgery and painful conditions of the lateral aspect of the lower leg and the posterior aspect of the upper leg. It is almost always necessary to block the saphenous branch of the femoral nerve or the entire femoral nerve additionally when this block is performed. It is advisable to perform a continuous femoral nerve block for surgery such as triple arthrodesis of the ankle, ankle arthroplasty, and other major ankle operations. When a mid-thigh tourniquet is applied, the catheter can be directed cephalad. If a mid-thigh tourniquet is not being used, but a lower calf tourniquet, a continuous popliteal approach to the sciatic nerve is probably a better choice. The sciatic nerve is formed from the fifth lumbar root to the fourth or fifth sacral root of the sacral plexus, and the bony involvement of this block will include the small posterior parts of the femur, lateral aspect of the tibia, the fibula, ankle joint, and the entire foot with the exception of the medial part. The neurotomes covered with complete subgluteosciatic nerve block include the posterior aspect of the thigh and knee, the lateral aspect of the lower leg and ankle, and the sole of the foot and lateral aspect of the foot. Almost all local anesthetic agents have been used for this block, but the preference of this author is to use 20 to 40 milliliters of ropivacaine, 0.5 to 0.75% for intraoperative analgesia, followed by an infusion of 0.2% ropivacaine at a rate of 5 to 10 milliliters per hour for postoperative pain management. Patient-controlled boluses of 5 to 10 milliliters are allowed with a lockout time of 30 to 60 minutes. The patient is positioned in the Sims position. The semicircle outlines the greater trochanter of the femur. Mark the midpoint of this and feel for and mark the midpoint of the ischial tuberosity. Draw a line adjoining these 2 points and measure and mark the midpoint of this line. Now draw a midline perpendicular to this joining line. This line is usually in a distinct groove between the iliotibial tract and the biceps femoris muscle and indicates the position of the sciatic nerve. The dotted line indicates the intended path of the catheter. After disinfection of the skin and application of a sterile fenestrated transparent plastic drape, the skin, subcutaneous tissue, and intended path of the tunneling of the catheter are anesthetized with a fine needle and lidocaine and epinephrine 1 in 200,000 solution. A 17 or 18 gauge insulated TUI needle, which is attached to a nerve stimulator set to an output of 1 to 2 milliamps, a frequency of 2 Hz, and a pulse width of 100 to 300 microseconds, enters the skin at an angle of approximately 45 degrees. The needle is aimed caudate in this illustration, but if the intended placement of the catheter is cephalad, the needle is aimed 45 degrees cephalad. Electrical stimulation of the sciatic nerve is indicated by a brisk plantar flexion motor response of the foot. More lateral stimulation of the sciatic nerve will result in eversion of the foot. The nerve stimulator output is now turned down, and brisk plantar or dorsiflexion of the foot at a nerve stimulator output setting of 0.3 to 0.5 milliamps indicates that the needle tip is placed in close proximity to the nerve. Do not inject normal saline or any other conducting fluid through the needle at this stage. The notion of opening up the space with normal saline to advance the catheter is not based on scientific fact, since in live tissue it only infiltrates the tissue, makes it edematous, and makes further nerve stimulation through the catheter impossible or difficult. The proximal end of the stimulating catheter is now attached to the nerve stimulator. This part of the catheter is placed in the palm of the left hand. The catheter tip is then placed into the shaft of the needle, and the muscle twitches should remain brisk and unchanged. Note that the broad black mark on the catheter indicates that the catheter tip is situated at the tip of the needle, but it is not yet protruding from the needle tip. The needle should never be manipulated if this complete broad black mark is not visible. If the twitches disappear, as in this illustration, the catheter is carefully withdrawn to inside the shaft of the needle again, such that the entire broad black mark is visible again. Make a small adjustment to the needle by rotating it 1/4 turn clockwise or counterclockwise, or by withdrawing or advancing the needle slightly and advance the catheter again. Repeat this maneuver as many times as necessary to ensure correct and accurate catheter placement and successful secondary block. In this recording, it can be seen that the catheter has been advanced for at least 5 centimeters along the sciatic nerve, and the foot twitches remained brisk at a nerve stimulator output of 0.4 milliamps. The needle is now removed without disturbing the catheter. The catheter is subcutaneously tunneled by first inserting the inner stylet of the needle from a point 1 to 2 millimeters from the catheter exit site and advanced laterally in the already anesthetized area. The needle is railroaded over the stylet removed, and the catheter fed retrogradely through the needle. The small piece of silicone tubing that protected the catheter tip during packaging is now handy to protect the skin under the skin bridge, which is left to make catheter removal easier. The snap lock is attached to the catheter and the nerve stimulator to the snap lock. The nerve stimulator output is turned up until brisk muscle twitches can just be seen. Immediately upon injection of the local anesthetic agent, the twitches will disappear. This constitutes a positive Raj test, which gives final confirmation that the secondary block will be successful. The catheter and snap lock are placed in the stab lock, which is placed in a convenient position on the patient's hip or abdomen. The catheter exit sites are covered with a transparent dressing to allow daily inspection. If the small silicone tubing is lost or not handy, the catheter itself can be used to protect the skin under the skin bridge, as in this demonstration. Catheter removal is a sterile procedure and is after the patient does not require the continuous nerve block any longer and after full sensation has returned to the leg. The proximal end of the catheter is fixed